All right, welcome to The Explainer. Today we're going to tackle a really important topic, male sexual dysfunction. We're going to build a clinical framework that you, as a medical trainee, can take and use right away in your practice. Let's get into it.
So first things first, why does this matter so much? Well, look at this number, 1 in 3. That's how many adult men are affected by this. This isn't some rare thing you'll read about once in a textbook. No, you are absolutely going to see this in your clinic, probably a lot. And that's why having a solid, confident approach is so critical. Okay, so here's how we're going to break it all down. First, we'll get our definitions straight. Then we'll walk through the patient evaluation and testing. After that, we'll dive into first-line and more advanced treatments, and we'll wrap up with the key takeaways you need to know.
All right, let's jump right in. Before we can even think about treating something, we have to know exactly what we're talking about. So let's define the 3 main categories here. So everything basically falls into one of 3 buckets. You've got low libido, which is all about desire. Then there's erectile dysfunction, or ED, which is about performance. And finally, ejaculatory disorders. Now, the key thing to remember is that these aren't isolated islands. They often overlap, right? It's totally common for a patient with low testosterone causing low libido to also have trouble with erectile dysfunction because of it. Okay, so now let's talk about your single most powerful diagnostic tool. And I'm not talking about some fancy, expensive scanner or a lab test that takes days to come back. I'm talking about your own 2 hands and your brain, the history and the physical exam. And this quote just drives that point home. 95% sensitivity. Think about what that actually means. It means that just by talking to your patient and doing a good physical exam, you're going to get to the root cause almost every single time. This is where good old-fashioned doctoring really, really shines. Okay, this is one of my favorite clinical pearls. Just one simple question, did this start suddenly or gradually, can be a massive diagnostic clue. It's like a fork in the road. If it happened all of a sudden, bam, out of nowhere, you should be thinking psychogenic, something like performance anxiety. But if it's been a slow, gradual decline over months or years, that's your classic signal for an organic problem, something physical, like vascular disease. So when you're doing the physical exam, you don't need to do a 2-hour workup. Be focused. Be efficient. What are the high-yield things to look for? Well, you definitely want to check their pulses for any vascular red flags. Feel for any plaques that might suggest Peyronie's. Look for signs of low testosterone, like gynecomastia. And a simple cremasteric reflex check, that gives you a quick peek into their neurological function. All right, so you've done your history, you've done your physical, and now you've probably got a pretty good idea of what's going on. The next step is using some targeted lab work to confirm what you're thinking and to screen for any other related issues.
Now, this is your go-to panel. You don't need to order the kitchen sink. This is about being smart and targeted. With these tests, you can efficiently screen for all the big players. You know, you're checking for diabetes with a glucose or A1C, looking at their lipids for cardiovascular risk, checking their thyroid, and of course getting that total testosterone to check for hypogonadism. It's a really efficient workup. Okay, this is a huge, huge takeaway. If a patient comes in with new onset ED, you need to think of it as a check engine light for their heart. Seriously, the underlying problem, endothelial dysfunction, is the exact same thing that causes heart attacks and strokes. So that means for every single one of these patients, you have to stratify their cardiac risk before you do anything else. It's that important.
Okay, so we've diagnosed the problem, we've assessed the risk. Now let's talk about treatment. And for most guys with ED, the starting point is going to be the workhorse of oral therapy, PDE5 inhibitors. So how do these things actually work? Well, let's keep it simple. Think of an erection as being started by a go signal. That's nitric oxide. The PDE5 enzyme is like the stop signal that cleans everything up. What these drugs do is they block that stop signal, so the go signal hangs around longer and works better. It's a really elegant mechanism, which is why they're so effective and why we use them first. Now, not all PDE5 inhibitors are created equal. You have to tailor the choice to the patient's lifestyle. It's a conversation. You ask them, do you need something that works fast? Then you're thinking Avanefel. Are you looking for something that lasts all weekend for more spontaneity? Well, that's tadalafil's claim to fame. Do you often take it with a big meal? Because a fatty meal can slow down sildenafil. This is what we mean by shared decision-making. It's about finding the right fit for that specific person. Okay, I cannot stress this enough. This is the one thing you absolutely positively cannot forget. PDE5 inhibitors and nitrates are an absolute contraindication. Taking them together can cause a catastrophic drop in blood pressure. It is life-threatening. So you have to ask every patient, every time, are you taking any nitrates? And that includes prescribed nitrates and recreational ones.
All right, let's talk about counseling. You gotta let patients know what to expect. The common stuff is pretty mild and all comes from that vasodilation we talked about. So things like flushing, a bit of a headache, maybe a stuffy nose, but you also have to cover the rare but serious stuff. Tell them, if you experience any sudden changes in your vision or hearing, you stop the drug and you call us or go to an ER immediately. That's crucial.
So what if the pills don't work or a patient can't take them? It's really important to know that's not the end of the line, not at all. There are plenty of other options. Let's walk through what comes next. This is the treatment ladder, and it's a great way to think about it. You always start on the first rung, lifestyle changes and oral meds. If that doesn't work, you climb up to the next step, which could be something non-invasive like a vacuum device. Still no luck? The next rungs are more invasive but also very effective, like penile self-injections. And right at the top of the ladder, for the most difficult cases, you have the definitive fix, a surgical penile prosthesis. Whew, okay. We have gone through a ton of information, so let's boil it all down to the absolute must-know points that you can take away from this. All right, if you remember nothing else, remember these 5 things. 1, ED is a window to the heart. Think cardiovascular disease. 2, your most powerful tool is a good history. 3, don't just prescribe a PDE5 inhibitor, choose the right one for that patient's lifestyle. 4, nitrates are a hard no. Always ask. And 5, don't give up on patients who fail pills. There's a whole ladder of other options. And I want to leave you with this final thought. It's really easy to just write the prescription and move on. But our job is bigger than that, isn't it? The real win comes when we look beyond the pill, when we also address the patient's heart health, when we talk about the relationship dynamics. That's when we stop just treating a symptom and start actually improving someone's entire quality of life. And that's really what it's all about.